Welcome to the new Camtasia Studio. We encourage you to watch and play with this Getting Started project video to learn some of the most important concepts of using the editor. If you want more in-depth tutorials that will walk you through the entire process of recording, editing, and sharing your videos, then please watch the Getting Started tutorials using this link under the Help menu. The editor is divided up into three main areas: the clip bin, the timeline, and the canvas. The canvas is where you see your video during playback and can move, resize, and reposition all media however you want. The timeline is where you assemble and edit your video. At the top of the timeline, tick marks represent time in terms of minutes and seconds. When building a video, you'll work in a horizontal manner, beginning from the left and moving sequentially through time toward the right. The tracks are layered on top of each other, so media you add on higher tracks is viewed on top of media on lower tracks in the canvas. For example, this callout is placed on top of the video track on the timeline, and therefore is on top of the screen video on the canvas. If I drag the video track on top of the callout on the timeline, the callout is now hidden behind the video on the canvas. Use the zoom slider to magnify the view of the timeline. This is very helpful when making precise cuts and selections, like removing ums in your audio. New media can be dragged and dropped on an existing track, or a new track is automatically created when media is dropped at this location at the top of the timeline. To change the position of a clip on the timeline, just drag it. To change the duration of a clip, drag the edges in either direction. An important part of the timeline is the playhead. To view your video, click play. Notice how the video and the timeline's playhead stay in sync. Click anywhere along the timeline and the playhead moves to that point. To remove a portion of your video, make a selection with the green in point and red out point. Then click the cut button. If you don't want media cut on a specific track, just click the lock icon. If you make a mistake while editing, press Ctrl-Z on the keyboard to undo, or choose Edit Undo. Double-click the playhead to deselect. Next, we'll look at the clip bin and the library. The clip bin holds recordings, audio files, images, and title slides being used in the project you're currently working on. The library stores video clips, intros, callouts, title slides, and other media assets you want to use from project to project. It is pre-populated with professional content you can use in your videos. You can download more media from our website by clicking this link. You'll find a lot more music, callouts, and animated titles to use in your projects, and it's all free. Once you find something you like this callout for example, just drag it to a track on the timeline and resize and reposition it as needed. Double-click the callout on the canvas to open the Callouts tab and edit the text, or change any of the text properties like color or size. You can find a number of other callouts to use in your projects by expanding the Shapes menu. You've probably noticed the video zooming in and out at times, for example here when it's zooming into the timeline. To learn more about adding and customizing zoom and pan animations to your video, check out the other Getting Started tutorials on our website. We've talked about some of the tabs already, but be sure to explore the others for adding and editing special effects. If they don't all show up as tabs, click on the More tab to explore others, like the speech-to-text capabilities and captions, and the improved quizzing. Also, transitions can now be dragged directly to the timeline and added on top of clips. So we've shown a few ways you can navigate and edit your video. But how do you get content into your video? To make a new screen recording, click the Record the Screen button. If you already have an audio or video recording you'd like to use, click the Import Media button. When you're done with your video project, you'll need to click the Produce and Share button to create a shareable video. Expand this menu to see a variety of presets. We have a new video player that plays back your MP4 video and includes other interactive features like table of contents, closed captions, quizzes, and even hotspots. These features are available when hosting your video on TechSmithScreencast.com or the video and player on your own web server. This player provides playback on multiple devices with just one video, whether it's a phone, tablet, laptop, or desktop computer. Well, it's time for you to try Camtasia Studio for yourself using the content on the timeline, or better yet, create your own. We have lots of free tutorials on our website, and I recommend you begin with the Getting Started series. Also, the help file inside Camtasia Studio tells you how to use each of the Camtasia Studio features and applications. One last thing, if you ever want to open this Getting Started project again to view or practice with, use this link here. Thanks for watching, and we hope you enjoy Camtasia Studio.
In this video module, we're going to review the different types of pain, and by understanding the different types of pain, it helps us identify the best type of treatment for each pain. So if we were to start off with two different categories of pain, we would split them up into nociceptive pain and neuropathic pain. And then furthermore, nociceptive pain can be divided further into somatic and visceral, and neuropathic pain is one category, but it can be defined as peripheral or central neuropathic pain. So let's take a look at each of these closely. So somatic pain, it involves the skin, the bone, the joint, and soft tissues. So you think of a musculoskeletal type injury, a sports injury, this would be a somatic pain. Pain is usually well localized, and the patient will describe the pain as sharp, aching, or throbbing. Pain is usually constant, so it's usually there most of the day. And there's predictable patterns with it. The pain increases with any movement, but then the patient may say, but at rest, the pain gets less. And a hallmark sign of somatic pain is that because it is well localized, the patient can usually point to the location or site of pain. So in this example, the patient would say, I have knee pain, and tell you exactly where that knee pain is. Visceral pain arises from afferent nerve damage of the soft tissue or viscera. So we're thinking about damage or injury around different types of organs. So the heart, the lung, the gastrointestinal tract, or the GU tract. And if the patient can describe it, they'll describe it as stretching, cramping, or distension type pain. As you can imagine, this is not external pain, so it's poorly localized and difficult to describe. And sometimes patients may just merely say it's deep, aching pain. And it also may be described as colicky or coming in waves. So if you ever think about a pregnant woman who's having contractions, those come in waves. Similarly, the visceral type pain could be described in this way. And then finally, onto neuropathic pain. And this arises from damage to the nervous system, whether it be peripheral nerves are damaged for various reasons, or there's injury to the spinal cord. And this type of pain is really hallmark because it's described, or the words that are used to describe it is burning, stabbing, shooting, numbness, which usually isn't thought of as painful, or electrical type pain. Now, this type of pain may be provoked by a stimulus that usually does not cause normal pain. So if somebody has neuropathic pain in their arm and you lightly touch it, they may feel like you're really punching their arm or hurting it really badly. And this is called allodynia because that area has become sensitized in the setting of neuropathic pain. So if we put it all together, we have nociceptive and neuropathic pain, and then underneath that we could further describe it as somatic, visceral, peripheral, or central. Another type of way to describe pain is whether it's acute pain, and usually that could be defined for a short period of time, about less than a month, or chronic pain. which is longer than that, and in some cases may be lifelong. In the setting of acute pain, you'll see pain, bruising, swelling. Usually in the setting of chronic pain, it's primarily described as just pain. In acute pain, you'll get temporary loss of function. And again, the key word is temporary. But in chronic pain, it will impair the patient, how the patient lives, and there will have to be coping on modifying how they do things in their lives because this pain is always there. You're more likely to get neuropathic pain with chronic pain because there's more likely a chance for you to have damage to the peripheral or central nerves. And then with any lifelong pain, there is progression of symptoms. So in the setting of acute pain, you would treat it as a scheduled therapy. So take this medication, 1-PO-Q12 for 7 days for a short period. Then you can take it 1-PO-Q12 PRN for 7 more days, and then the pain should go away after that or get less. Now, in the setting of chronic pain, where it's a longer period or lifelong, you're going to have to schedule the medication that you're going to use for their pain management. So you take this medication, 1-PO-Q12. And then in addition to that, you can give them a PRN medication. So your first medication, you're going to take 1-PO-Q12, and the second medication, you're going to take 1-PO-Q4 PRN pain when the pain spikes up from its average pain. Joel, we're going to talk about the types of questions you would ask to appropriately assess someone's pain. Now, there's different ways and there's different titles. A learning tool is this one called PQRSTU, and it was taught to me by Dr. Mary Lynn McPherson at the University of Maryland. And it's a good way to subjectively assess someone's pain as on the initial visit and follow-up visits. So P would stand for both palliation, what makes it better, or precipitation, what makes it worse. Q is quality. Is it visceral, somatic, or neuropathic? R stands for both region, so where's the location of pain, if the patient can tell you, and radiation. Does it travel from one area to another? And usually this is indicative of a neuropathic component. S is for severity, and you can use different scales to assess the severity. The most common scale used for adults is the numeric rating scale, which ask the patient from a scale of 0 to 10, where 0 is no pain and 10 is the worst pain you can ever imagine. What is your pain right now? T is for temporal. So this assesses two things. Is it constant? Is the pain there all day? Or is it intermittent? Does the pain come and go? Is the pain chronic or acute? And then the U is how it impacts you, the patient. So how does it impact the patient's sleep and their daily activities and any other relevant information that would be important that the pain is preventing them from doing? Objective pain assessments can include past medical history, anything you see on physical exam, and any imaging that may be available. So when you're monitoring the patient, especially if you're starting them on a medication, you want to see if there's improvement. And the way to assess this is to look at the subjective responses by the patient and the objective. And in the subjective, the patient is telling you in some way or other that there is an improvement in the PQRSTU. And in the objective, there's objective measures within PQRSTU that you can look at, such as a decrease in severity of pain, whether that be a number or they just tell you their pain is better. If they tell you they're sleeping longer, and if originally the pain was preventing them from sleeping, and any functional impairment that the pain was initially causing that now is starting to be restored, such as are they able to walk further, Or are they able to return to work if that was one of their goals and they couldn't do that? Or are they able to work longer? So some of these will have to be very specific for that patient, their goals, and what is the realistic goals of what could happen.